All right, let's do this. Today, you're in the hot seat. We're going to run a simulated consultant-level viva exam in general surgery, and you're the candidate. I've got 3 complex thyroid cases lined up, each designed to really push your clinical reasoning to the limit. Ready? Okay, so you've entered the room. Take a seat. I'm going to present the first scenario. I want you to talk me through your management from the very beginning to the very end.
So let's kick things off with a really tricky one. We're talking about a patient who has thyroid cancer and she's pregnant. This is where the decision-making gets really complex.
Okay, here's the situation. She tells you this mass has been growing. She has no pressure symptoms, no signs of her thyroid being over or underactive, and, this is important, no family history of endocrine cancer. Keep that last part in mind.
So she's sitting there in front of you. What's your game plan? Walk me through your initial assessment, step by step. What are the absolute first things you are going to do?
Right. And the perfect answer here is all about structure. You have to be systematic. You'd start with a really focused history, zeroing in on that growth rate and making sure to rule out any pressure symptoms. Then, a thorough physical examination. You know the drill. Get behind the patient, have them swallow, and carefully, methodically palpate the entire neck. You're hunting for any suspicious lymph nodes.
Excellent. Your clinical picture is starting to form. What's next on your list? How are you going to investigate a pregnant patient with a thyroid nodule? Be specific.
Okay, so the results are back. Her thyroid function, totally normal. But the ultrasound, that shows a pretty suspicious mass. And here's the bombshell. The fine needle aspiration comes back positive for papillary thyroid cancer. That one result changes absolutely everything.
So you get this diagnosis in the second trimester. The standard approach is to start with active surveillance and TSH suppression. You're basically watching and waiting. But just 6 weeks later, you do another ultrasound, and that tumor has doubled in size. This is a massive game changer.
All right, the tumor is clearly growing aggressively. Your initial plan of watchful waiting is officially out the window. What is your definitive management plan right now at 23 weeks gestation?
Okay, so surgery is the clear path forward. The first step is a really careful, honest conversation with the patient about why this is necessary now. Then, your pre-op checklist has to be perfect. You need a formal vocal cord assessment, you're getting anesthesia and obstetrics involved for a multidisciplinary plan, and of course, you obtain detailed, informed consent for a total thyroidectomy.
Okay, let's switch gears. Case number 2. This time, the patient is showing up with some pretty obvious signs of locally advanced disease, and that brings a whole new set of challenges to the table.
On examination, you find this big, hard, fixed mass on the right side of his neck, and you can feel a whole chain of enlarged cervical lymph nodes. This is not subtle at all.
That hoarseness, that is a massive red flag. In any thyroid viva, the second you hear hoarseness, your brain should be screaming recurrent laryngeal nerve involvement. You're already thinking this is advanced disease, even before you've seen a single scan.
So, you've spotted the red flag. Now what? How are you going to prove your suspicions and properly stage this disease?
And sure enough, your investigations confirm your worst fears. The FNA is positive in both the thyroid and the nodes. It's metastatic papillary cancer. The CT scan, it shows a huge tumor that's actually pushing the trachea to the side. And that vocal cord assessment you ordered, it confirms what you suspected clinically. The right vocal cord is completely paralyzed.
Okay, fast forward. You're in the operating room, you've exposed the tumor, and you can see with your own eyes that it's invading the recurrent laryngeal nerve and the internal jugular vein. What's your move? Right now, in the OR, what do you do?
Okay, surgery's done. You get a call from the recovery room nurse. She's worried. Your patient is having spasms in his hands and feels tingling around his mouth. What is the diagnosis, and what are your immediate orders?
This is textbook acute hypocalcemia. You have to act fast. You suspect it clinically, you immediately send blood for an urgent calcium and albumin level, but, and this is key, you do not wait for the result. You give IV calcium gluconate now.
All right, for our final case, we're going into every surgeon's nightmare scenario, a major complication during the operation. So here's the setup. Your patient has a 3-centimeter thyroid nodule, and there's a family history of thyroid cancer, which really raises the stakes. The FNA comes back as Bethesda 3, follicular lesion of undetermined significance. This is a tough spot. There's a 10 to 20% chance it's cancer. How do you counsel the patient? What do you recommend?
Okay, so you've taken the patient to surgery.
You're in the middle of the operation. The anatomy is difficult, the nerve is hard to identify, and then you get that horrible, sinking feeling in your stomach. You've just cut the left recurrent laryngeal nerve. What do you do in that exact moment? What is your very next step?
The only correct and safe answer here is to stop. You finish taking out the diseased left lobe, but you do not proceed to the other side. You terminate the procedure. And why? Because if you injure the other nerve, you've just caused a bilateral vocal cord palsy, and that patient is getting a tracheostomy. Patient safety always comes first.
So let's wrap this up. What are the big takeaways here? A structured approach is your best friend in these exams. You have to recognize clinical red flags like hoarseness. You need to know how to manage those tricky, indeterminate nodules. And when complications happen, because they will, you have to have a rock-solid plan for things like hypocalcemia and nerve injury. But the number one rule, patient safety trumps everything, especially in a crisis.
Excellent. You've demonstrated you know how to manage a nerve injury when it happens. But the real mark of a consultant is preventing it in the first place. So the question I'll leave you with is this: what are the specific techniques, the habits, the mental preparations you use to make sure that crisis never happens? That's what separates the good surgeons from the great ones.